I have 11 o'clock, and so we will get started with our program today. So excited to see individuals joining the call and having time to break away. We know everyone has been extremely busy again with the recent COVID surge, and just hope everyone is well and families are safe. Today's program for the Flex Quality meeting is the Changing Landscape of Quality Measurement with Karla Weng, who is a Senior Program Manager at Strata Health. But before we begin, I just want to thank Allie Orwig for supporting Zoom. Allie's with the Indiana Rural Health Association, and also to David Conrad and Joyce Fillenworth at the State Office of Rural Health. They're back out again, helping with some COVID activities during their work week and trying to cover and make sure that everybody has the resources that they need and require just for day-to-day activities. So always reach out to them if you have questions that you're unable to get answered. Our program today, as I said, is focused on quality measurement and kind of just some of the changes that are coming through, and just hopefully provide some clarifications as well. Karla Weng is the Senior Program Manager for Strata Health, and she leads their rural focus programs there. And I've been working in the quality arena for around 30 years now, and Strata Health has always been a strong advocate of rural health and really have a lot of admiration for their organization. They are the Rural Quality Improvement Technical Assistance Group, or you might see from time to time the acronym RQITA, that they are kind of our national support center for the MBEquip program and are always very good to seek out any clarifications that we have and keep us up to date. So at this time, if you want to make sure you open up the chat function, and if you'd like to chat in any questions that you have along the way, I will make sure that those are addressed. Also, if you have more than one individual in the room, if you could chat in the other individuals there. We like to take attendance and see who all is attending our programs. And feel free at any time if you'd like to unmute your line and ask questions. We encourage you to do that too. So if you click onto the participants and unmute the microphone that is beside your name in the participant list, that will allow you to also answer questions directly. So Karla, I will turn the program over to you.
All right, thanks Becky, and thanks to everybody for joining us today. Just a brief context setting about where the lens that I come to with this. Becky highlighted this a bit, but I am with Strata Health. We're a nonprofit based in Minnesota. We focus on leading collaboration and innovation in healthcare quality and safety. And really a lot of what we do is facilitating improvement initiatives, trying to help connect people and communities with healthcare resources. We like to say that we work at the intersection of research, policy, and practice. And today's session is going to go a bit into the policy wonky weeds, but I hopefully am going to, my goal today is to try to help interpret those wonky policy weeds for you, what the potential impact is, and give you sort of a little bit of a lens on what, hopefully connect some dots and what might be coming into kind of the quality space. So we do have a long history of working with rural providers, critical access hospitals, and the Flex program. We have 77 critical access hospitals in Minnesota, so have worked with those critical access hospitals here locally for the more than 20 years actually that I have been at Strata Health, but have also been working nationally with critical access hospitals in the Flex program for probably about 15 years now. We are the Rural Quality Improvement Technical Assistance Center. So Becky already introduced that. So I am going to skip this slide. This is what we're going to really dive into today. So I will admit that I don't know that any of this is going to be immediately useful to you all. I think there's COVID surge happening in Indiana as there is in lots of other places in the country. But again, my goal is really to hopefully give you some thoughts to help connect the dots of what you might be seeing and hearing out of CMS in terms of quality measurement programs, how that connects back to the MBEquip program. And then as you get a chance to start to lift your head and look forward and think about what direction you want to take your quality program at your hospital, give you some thoughts about where I think the overall kind of direction is going in terms of quality measurement and the focus areas of CMS. So definitely a bit bigger picture session today, but also going to go into some of the policy weeds. So please do ask questions. I know that I talk fast. There's lots I want to share with you, but I am definitely happy to pause and try to make sure that we're clear on things. So we are going to talk about overall hospital star ratings. There's been a significant shift in the way that those are calculated. We're going to talk about electronic clinical quality measures, also some pretty significant shifts in the way that those are being utilized. Talk about some recent and anticipated changes to some of the CMS quality measures, and then how that all connects back to MBEquip. So first, just a reminder of what MBEquip is. It's the quality improvement activity under the Medicare Rural Hospital Flexibility Grant Program, or the FLEX program, and it stands for Medicare Beneficiary Quality Improvement Program. It's not just the quality for Medicare beneficiaries, but it's the Medicare Rural Hospital Flexibility Program, so that's why the Medicare word is there. It's really looking at quality in general, hoping to help support improvement of quality of care in critical access hospitals by increasing quality data reporting and driving improvement based on the data. So there's a common set of rural relevant hospital metrics, technical assistance, encouragement, and it also allows the Federal Office of Rural Health Policy, who funds the FLEX program and the Rural Quality Improvement Technical Assistance program, to help demonstrate the impact at a state and hospital level in terms of quality improvement efforts. The goals of MBEquip are really around quality measurement, quality improvement, and improved patient outcomes. So we know we end up talking a fair amount about reporting, but the reason to report is that you have the data that allows you to improve. So really the overall goal is on improvement and helping get to those improved patient outcomes. It's also really a, I would say, takeoff ramp in terms of participation in value-based care programs. So I know that the reporting systems for MBEquip are somewhat complicated. So here's an illustration of the core measures and where they get reported in. But part of the reason for really trying to align with the federal quality reporting systems is that although I've been saying this for a few years, I do anticipate at some point that CMS is not going to continue to allow critical access hospitals to not report some of these measures. So this is really a voluntary opportunity for you to be understanding how the systems work, what it looks like, get that infrastructure in place for reporting. For the larger hospitals, there was about a 10-year kind of on-ramp from when voluntary reporting was available to when there was money attached to reporting to when there was money attached to quality performance. So I would envision this as sort of your voluntary on-ramp. I think all indications are that there's direction towards more focus on outcomes and metrics in terms of quality. And I don't think critical access hospitals will continue to be left out of that. So this is just kind of a summary. So most of the data goes up through the hospital quality reporting site, which used to be known as the Quality Net Warehouse. CMS has changed the names of lots of things on us in the last year, so I've been trying to catch them on all my slides. NHSN through the CDC is where some of the other data is reported, and then the Emergency Department Transfer Communication Measure goes directly to your state flex office. That's the only measure at this point that isn't also part of another federal program. So that one has been identified as really being specifically useful to critical access hospitals, since you often do a lot of triage and transfers. So the federal office decided to keep that measure in place, even though it's not aligned with one of the other programs. So in terms of the policy weeds, if it feels like the quality measures are changing regularly, they are, and that's because they are all kind of identified and updated and changed through the annual rulemaking process. So there is an inpatient prospective system payment system rule that's released by CMS every year. And in addition to kind of lots of other things in part kind of the payment infrastructure, it also defines the inpatient quality reporting program and the promoting interoperability program. So the inpatient quality reporting program is where most of the quality measures sit, but the electronic clinical quality measures are under the promoting interoperability program. And we're going to talk about that in a bit. There's also an outpatient prospective system payment system rule, and that defines the outpatient quality reporting program. So if it ever seems like the inpatient side and the outpatient side don't quite match up, even though your emergency department is attached to your hospital and you probably run it with the same staff, it is true that they don't match up. It's entirely different sets of staff, and it's entirely different rulemaking set of what happens in terms of the outpatient and the inpatient side from CMS. So they've done, I think, a better job in the last couple of years of really trying to align the two programs, but they are on slightly different timelines, and they have different sets of staff at CMS that actually manage and run those two programs. When they're looking at quality measures, they are typically endorsed by the National Quality Forum, but not always. There's actually even a pre-rulemaking process that happens typically in December, January, February, where the National Quality Forum has something called the Measures Application Partnership that reviews potential measures for rulemaking and makes recommendations. CMS then takes those recommendations and turns it around into a proposed rule, asks for feedback, and then a final rule comes out. So this is kind of an ongoing annual process. There is just recently in the last 2 years that MBEquip group has added a specific rural work group to be looking at the measures. So that is, I think, a step forward. CMS doesn't have to take any of those recommendations from MBEquip. They are purely recommendations, but there is a process. But what you see through this sort of annual ongoing process is that the measures are regularly added, topped out, retired, or removed. And I think we've seen that in particular, some impact on the measures that have been relevant for smaller rural hospitals. So if you've been around quality reporting for the last few years, you might have noticed that there's been a lot of measure changes. So this table just shows you that when we started having core measures for the MBEquip program back in 2014, these were all the measures that were available. All the ones that are grayed out have been retired or removed from CMS. So you can see that a lot of these measures that I think many small rural hospitals found useful are no longer available. And why, you might ask, that is happening, that is what I am going to talk about next. So we'll talk a little bit about the changing landscape here. I only have one slide in this section because I think CMS has actually done a pretty good job in giving me a picture to kind of give the overall sense of what is happening. So CMS, in addition, like most organizations, does some strategic planning essentially, and every couple of years they update and refresh the framework that they're using that kind of sort of guides what they're doing around quality measurement. So this is actually the Meaningful Measures 2.0. There was a 1.0 that came out in like 2017 that started to use some of these same concepts and same focus areas, but it's been refreshed about a year ago. It's actually this is quite a bit simpler than the earlier one was. So it really is helping set the direction for what's happening across all of the CMS quality measurement programs. And one of the things that's been a primary shift in recent years is that they're really prioritizing what they call outcome and/or patient-reported measures and kind of de-emphasizing process measures. So a lot of those measures that have been removed that were relevant to many rural hospitals were process measures, and CMS is really sort of getting away from using process measures in their program. So you're seeing things more focus on things like mortality, patient safety, readmissions, which are kind of on the farther end, versus did you administer aspirin or did somebody get a flu shot? So you're starting to see a little bit in a shift in that. Although the vaccination ones, I think we're going to see some shift on going forward. They have stated they want to use quality measures of the highest value and focus on key quality domains. And if you can see it in my little house here, this is their picture. So they're looking at care coordination, behavioral health, chronic conditions, safety, wellness and prevention, person-centered care, equity, affordability, and efficiency. So most of those categories were in the Meaningful Measures 1.0. Equity was not. That is a recent add, and you will definitely start to see that threaded across what's coming through in the different quality measures. CMS is really starting to look at how they can use quality measures and quality reporting programs to better understand and reflect both social and economic determinants of health. So trying to do some looking at how that makes a difference, and is quality different across different types of subgroups, subpopulations. They're also really emphasizing this consumer and caregiver voice piece. You can see it really kind of as the foundation across the bottom. That certainly your HCAHPS or your patient experience plays into that, but they're also looking more and more for something called patient reported outcome measures. Sometimes you see the acronym PRO or PROM, so patient reported outcome measures. So if you see the word, see a PROM in all caps, that's what that stands for. So an example of this would be a measure that they're starting to talk about. For example, there's a metric that looks at if you do hip and knee replacements, do you have a survey questions for the patient? I think it's 30 days afterwards, it might be 60, that asks them how are they better? Did it make a difference? From the patient's perspective, did it make a difference? So I think we're going to see more focus in that space in terms of development of quality measures. We're also seeing a really significant push towards transforming what they're calling measures to be fully digital. So I think we're seeing it more with the emphasis on electronic clinical quality measures, and across the programs using more claims data, using more of the EHR and IT system type data. So I'm a little skeptical that they'll get there by 2025. And I can share my reasons why for that when we start talking about ECQMs. I think they set lots of goals, and then the reality of the systems in place sometimes takes longer to get there than they think. But I do definitely think this continues to be the direction that they are headed. I am trying to be optimistic that they will also be able to start to incorporate all payer data. When we talk about the hospital quality star ratings, the mortality measures and the readmissions measures that they use for that program are all calculated off of claims data, which is only Medicare fee for service. So it doesn't include your commercial or your Medicare Advantage or your Medicaid patients. So if they were able to actually use data across all payers as they're looking at those claims data, you would get a much fuller picture of what that is looking like when they're using that as a data source. There's lots of challenges. Some states do have an all-payer database. I don't know if Indiana is one. It's somewhat controversial in terms of having everything all together in one database. So I'll try to be optimistic that CMS is going to get there, because I think that would actually be a really good thing for quality. But whether or not they're able to get there in the next now 4 years, we'll see. So I hope this gives you just a little bit of a sense in terms of when you start to see and hear things about what's coming out from CMS, that this is really kind of the direction that they're headed. Is there any questions on that before I keep going? Because this is the 90,000 foot, and then I'm gonna dive into the weeds.
I'm not seeing any questions in chat right now.
Okay. Okay, so we're going to dive into the weeds and talk about the star ratings. So if you guys know how to click on the, I would love to know how many of you, if you can kind of click on the little raise your hand, or on the where you kind of do a reaction, how many of your hospitals have a star rating calculated, if you know that. So to do that, you can click on, and it looks different for me because I am the presenter.
If you hover at the bottom of your screen, it should bring up a bar, and there's a reactions button. And if you click on that, you'll be able to raise your hand.
Thank you. Oh, so many of you. Excellent. Okay. Awesome. Thank you. Okay, so we're going to dive into star ratings, and they are complicated, and hopefully this is going to help clear some things up for if you have questions about them. So this is the overall hospital quality star rating. CMS has stated that the intent is to summarize the information from existing hospital measures posted on Care Compare. They don't call it Hospital Compare anymore. It's now called Care Compare. But their intent is that it kind of summarizes that information in a way that's useful and easy to interpret for patients and consumers. Whether or not patients and consumers actually use the overall hospital star rating is a really big question, but certainly payers and leadership and health systems and other partners are looking at overall hospital quality star ratings. So that's part of the reason it's important to kind of be paying attention to them. They initially released the hospital quality star ratings back in July 2016. They followed the CMS release of star ratings across a variety of other healthcare provider types. So nursing homes have star ratings, Medicare Advantage plans have star ratings, hospital star ratings were not the first. And they came after and are separate from the HCAHPS star rating. So if you have at least 100 HCAHPS surveys returned in the most recent 4 quarters, you will get an HCAHPS star rating, and that is separate. So if you go out onto Care Compare, you would see your HCAHPS star rating and your overall hospital star rating as 2 separate ratings. So HCAHPS plays into your overall hospital quality star rating, but it is posted separately as a separate rating. And it's really important to note that it summarizes the current Care Compare measures into a single star rating. So every time that they recalculate the star rating, they pull down the current data. And if you will recall, I showed you all those measures that have been retired in the last couple of years. So almost every time that they're pulling down the data, the set of measures that they're looking at varies. About 20% of hospitals nationally, primarily those that are small and rural, consistently don't meet the threshold to have a rating calculated. CMS held quite a few stakeholder meetings back in 2019. They actually worked with federal office to do one specifically focused on rural and critical access hospitals. And then they made some pretty significant changes to the star rating calculation. So this all went through that rulemaking process that I talked about. So last year at this time, they had proposed the changes and then it came out in the final rule late last year. And then they updated the star ratings using the new methodology on Care Compare in April of this year. I am not going to go through the whole process in detail, but I want you to have the big picture of this. Essentially, they take all of the current measures that are available on Hospital Compare, they put them into groupings, so mortality, safety, readmissions, patient experience, and what they're calling timely and effective care. They calculate a score for each of those groups and then roll that up to a hospital summary. And then they apply the thresholds at that point. We'll talk about the thresholds a bit. If you meet the threshold to have a star rating calculated, they now apply peer groupings. And this is a brand new piece to the methodology. And I think it's one of the ones that's having a bigger impact on critical access hospitals. So we'll talk about that a bit more. And that's how you end up with your star rating. So this is the overall flow of what happens with the data. Some of the big changes, they shifted from 7 measure groups to 5 measure groups. So there's these 5 that are available now. There used to be 3 that were more around those process type of measures, which I mentioned earlier that they're really starting to de-emphasize. So they rolled the rest of the process measures that are still available around effectiveness, timeliness, and efficient use of medical imaging all into one bucket now called timely and effective care. So that was one of the big changes. They also made a fairly significant change in the criteria around thresholds. So I'm talking about on the next slide, but first, just mortality. I did send one of the links that I sent that Becky sent you is actually a list of all the measures that were in the April 2021. So if it's helpful for you to be kind of looking at that, it might help you give a little better sense. The mortality is the death rates from a variety of patient groups. So it looks at like heart failure or pneumonia or AMI. It is again all calculated off of Medicare fee-for-service claims. The safety of care measures are hospital-acquired infections that are reported through NHSN, and then there's a couple of complication measures that are calculated through claims. Critical access hospitals rarely have enough data to have the complications rates calculated and rarely have enough data to have a CER calculated for any of the hospital-acquired infection measures. So often don't have the safety of care measures included in their score. Readmissions is readmission rates and hospital return days, which again is calculated off of claims. The hospital return days measures, those are the ones that say EDAC, which I'm not going to remember what that stands for off the top of my head. It really is a broader look at that. So it's not just readmissions, but they're also looking for whether or not patients had emergency department visits or observation stays after a hospitalization. So it's a bit broader look at return. Patient experience is HCAHPS. If you don't have at least 100 return surveys in the period that they're looking at, you won't have that calculated as part of your score. And then the timely and effective care are the things that we might typically think of, some of the quality measures like the outpatient AMI measures or the healthcare provider vaccination measure.
Karla?
Yep.
Before you move on, a question was sent to me. For the readmissions for a patient, which hospital is given credit for the readmission? And I believe what they mean is once a patient is readmitted, if a patient transfers out of a critical access hospital into another facility, who actually is credited with that readmission? Which hospital?
So if they are transferred out of the emergency department and never admitted as an inpatient, then it would be the receiving hospital. If they're an inpatient in a critical access hospital and then transferred, to be honest, I'm not sure. I'll have to check. So if they're an inpatient and transferred then to an inpatient in another facility in that index stay, I will have to check.
Okay.
I think that it goes to the hospital that discharges them, but I'm not entirely sure. So I'll check and circle.
Okay, thank you.
Yep. And it doesn't matter where they're readmitted. So if you have the inpatient stay and they're readmitted down the road, it still counts towards you if you were the one that had the inpatient stay and discharged them. So it's all cause for the readmissions measures as well.
Thank you.
Okay, yeah, I gotta write myself that note. Okay. All right. Some of the other methodology changes. So you might have noticed that I have mortality and safety care in a different color. There's a reason for that. The threshold to have a rating calculation has not changed, but they changed some of the definitions. So to have a rating calculated, you have to have at least 3 measures in at least 3 of those groups. And one of them must be what they're calling an outcome group. So that's been what the rating has, what the threshold has been previously, but they've changed what they're counting as an outcome group. So they used to count readmissions as an outcome group. So then now they're only counting safety of care and mortality. So you have to have 3 measures in at least 3 groups. One of those groups must be either safety of care or mortality. So as I mentioned earlier, critical access hospitals rarely meet the threshold to have the safety of care measures reported on Care Compare. And if they do, they almost never, if any, have 3 of those measures. So if you're ending up in the threshold to have a rating calculated, it's most likely because you hit the threshold in mortality measures. And just so you're aware, because the data is old. So the mortality measures are calculated using claims for a 3-year period. And the April 2021 release used 2016 to 2019 data. And it is only Medicare fee-for-service claims. So I've had a couple hospitals contact me and say, we have a lot bigger volume than the hospital 30 miles down the road. Why do they have a rating and we don't? Well, it really could be the difference between 1 or 2 patients 3 years ago in terms of whether or not you fell in or out of those mortality measures. So the cutoff for most of those is 25 patients. So if you had 25 pneumonia Medicare fee-for-service patients between 2016 and 2019, you would have that rating, that measure calculated for you. So if you have that table that I sent along with Becky, that's where you can see all the timeframes and how that's calculated out. A couple other changes to the methodology. This was a big one was that they simplified the statistical method. That was one of the biggest complaints about the methodology, is that it was just way too complex and nobody could replicate it. It used to use something called latent variable modeling and Windsorization, which I won't even try to explain to you. And I'm glad that I no longer have to feel like I need to explain it to anybody because it was really complicated. They really have now just shifted to a simple average of the measure scores. They also updated the weighting by measure group, in part because they removed a couple of the measure groups. So again, I talked about the de-emphasis on the process measures. You can see here in the weightings, they are have higher weights for mortality, safety, readmissions, and patient experience, and then a lower rating for the timely and effective care, which is essentially your process measures. So if you don't have measures in all 5 areas, which most critical access hospitals don't, they reproportion the weights. So for example, if you have measures in the mortality, readmissions, and timely and effective care groups, they would reproportion that. So your mortality would be roughly 39 to 40%. Your readmissions would be about 40%, same. And then your timely and effective care is roughly 20%. So they just reproportion what that looks like. If you meet the threshold to have a rating calculated, all of the measures that are available are included. So this is another kind of catch that I've been hearing from a handful of hospitals, is that they met the threshold. They only had one patient safety of care measure that was calculated. That ends up being a pretty significant amount of your score, because that one measure is calculated and weighted at the weight of the safety of care group. So I hope that makes sense. So if you have to meet the 3 in 3 areas, one of them has to be mortality or safety. But then once you've met that, any of the measures are part of your rating. So the biggest change to the methodology was around peer groups. And so one of the other primary complaints about the methodology was that, is it really fair to compare large tertiary academic medical centers to small community hospitals? So for example, your critical access hospital to Johns Hopkins, who's my favorite one to pick on for that. I don't know why. I don't think you like it, and I don't think Johns Hopkins likes it, to be honest. So what they have done is their approach to sort of address that is, what they've done is peer grouping based on how many measures that you have available. So I think it would have been preferable to peer group based on hospital characteristics, but that is not what they have done. They have done it based on which measures you have available, or how many measures you have available. So now what they're doing instead, what used to happen is everybody would be all the scores would be together, and they end up being sort of in a bell-shaped curve. And then they do something called K clustering, which is a statistical method where they apply cut points. So if you're out kind of on the ends, you're either a 1-star or a 5-star. And then kind of through, and so your kind of middle grouping is your 3-star. So you have your bell-shaped curve and your cut points. When critical access hospitals were bell-shaped curved in with everybody else, they almost never fell out on the 1-star end. When you start to do more comparable groupings, so if you're now comparing hospitals with only 3 measure groups, the majority of those hospitals are critical access hospitals, you're still applying a bell-shaped curve, and you're still doing cut points, but you are now comparing like to like. So you have more critical access hospitals getting 1 or 2-star hospitals, because 1 or 2-star ratings, because you're comparing them to like facilities. So you're starting to see it's just how they applied. So I think the intent is a good thing. I don't think that they should be comparing critical access hospitals to the Johns Hopkins of the world, but I don't know that the methodology really got there. And if you're one of those hospitals that fell out on the lower end, you're definitely not happy about it, which I would agree, which I totally understand. So this is just an example of sort of what happened with this. So the previous method, in the January data, there was only 1 critical access hospital with a 1-star rating. Using the previous method with the October data, you wouldn't have had any critical access hospitals with a 1-star rating. Using the revised method with the October data, you had 26 hospitals, critical access hospitals with a 1-star rating, and 94 with a 2-star. So again, that's really primarily about how they changed that peer grouping and the slicing and dicing of that. It also makes a pretty big difference that in January 2020, rating had 54 measures. April 2021 only included 48, and several of the measures that dropped out were relevant to small rural hospitals. So you can also see that it's still the majority of critical access hospitals are not rated. So with the revised method, there's only about 40% of critical access hospitals actually receive a rating, which some of the methodology changes kind of blunted that, because if they would have gone with the previous method, it would have been only 30% would have gotten a rating, but it's still higher than it used to be, in part because of the drop in the number of measures that were available to be calculated. So I would say, so my message about the kind of methodology is that I think it did address many of the concerns that had been raised, but it certainly did have an impact, and more critical access hospitals will have a 1 or 2 star rating. So my soapbox, which you'll hear a couple times from me, is that the availability of rural relevant measures, I think, is the bigger concern than the actual methodology. So if you think about the methodology as a recipe, like if you like to make chocolate chip cookies, there are about 100 different ways you can combine essentially the same ingredients to make hot chocolate chip cookies. So that's your methodology. How are you combining and putting the information together? But if you're missing half of the ingredients, it doesn't really matter how good the recipe is. The cookies aren't going to turn out very well. And so at least they're comparing the cookies that have the same ingredients, but we're still missing most of the ingredients. So until we kind of have measures that make sense, it doesn't work very well to have a recipe when you're missing so many of those pieces. So part of what we're going to talk about is some of the changes that are happening in measures that I think will impact this down the road, but I think that availability of real relevant measures continues to be really a primary concern. Okay, I'm going to keep going because I'm taking too long and I want to cover some other things. So please ask questions as we're going. I'm going to talk through ECQMs fairly quickly. And ECQM, just level setting, is nothing more than a quality measure that's pulled or extracted from your electronic health record. So nothing fancy, but I just always kind of want to level set there. So this is CMS stated this is their vision for ECQMs, and I want to highlight for you when it was posted. So this was back in 2016 in the proposed rule. And at that point, they said that hospitals should be able to primarily switch to EHR-based data reporting. And they were quite optimistic. What they were proposing was that in 2017 would sort of be a test year. And then by 2018, everybody was going to be essentially submitting all of their measures all the time using this method. Well, clearly we're still not there 5 years later, which is why I'm a little skeptical of the 2025 for all digital. I do think we're going that direction, and I think it's only going to accelerate, but I think things take longer than they anticipate. But we have seen, especially in the last year of rulemaking, some pretty significant changes. And I will remind you that although the inpatient quality reporting and outpatient quality reporting measures are not required for critical access hospitals by CMS, the Medicare Promoting Interoperability Program is. So it used to be called the EHR Incentive Program. A lot of people called it Meaningful Use. That program is required for critical access hospitals, and that's where the ECQM reporting requirements sit. So if you were a larger PPS hospital, they have aligned the reporting requirements between IQR and promoting interoperability. But as critical access hospitals, these requirements do apply. And what we're seeing, and this just came out last year, is now a progressive increase of reporting requirements for quarters. So since they started the ECQMs, it has essentially been pick 4 of the available measures and submit them for 1 quarter. So this year, 2021, you can see that it's pick 4 of the available measures and submit them for 2 quarters. Next year's 3 quarters, the following year is 4 quarters. They are also starting in 2022 requiring the safe use of opioids ECQM. But if you can see my little caret in my table there, there's actually in the proposed rulemaking right now a request for information asking about whether or not they should require that. So that may or may not stay in place. At this point, if I were you, I would plan on looking at reporting that measure in 2022, but it may or may not stay as a required. We'll see what happens in the rulemaking process. But they're definitely looking at sort of upping the ante here in terms of how often they, the reporting on this. This is the available measures for 2021. The blue and orange, if you can see the colors, are my take on what's relevant in rural. I think that the safe use of opioids is actually relevant for most rural hospitals. The VTE1 and the median admit decision time to ED departure is also, I think, relevant for most critical access hospitals. If you do labor and delivery, the exclusive breast milk feeding is also relevant. The others, not so much. Most critical access hospitals don't have ICUs, and not very many critical access hospitals keep their stroke patients. So there are a handful of these measures that are available, including this ED2 that's actually now slated for removal beginning in 2024. So this will start to look a little bit different. Again, my carrot on these ones, if you're looking back at this, are the measures that have been finalized to be removed, but not until 2024. So what does reporting mean? It's essentially that you submit something called a quality reporting data architecture, or QRDA1 category file. It's like a flat data file with all the patient information. So you have to either submit the data file, you can do a zero denominator declaration, or a case threshold exemption, which are similar. So both of those go into the hospital quality reporting system through your HARP account. And essentially it's either saying I didn't have anybody in the denominator, or it's saying I had less than 5 people in the denominator for that reporting quarter. There is a hardship exception, but it is on a case-by-case basis. It's not a blanket exemption. So there's more information at the link here if you need to pursue that, but it is something that they would review on an individual basis. And this is probably, in addition to kind of the ramping up the reporting requirements, the biggest change is that CMS is going to start reporting the ECQM data on Care Compare. So remember when I said hospital star ratings, pull the current Care Compare data. So if your ECQMs are reported on Care Compare, when they start pulling the hospital ratings, those ECQMs will be included in those hospital star ratings. So that's the connection back between the two. They will start the public reporting with the 2021 data. So the data that you will submit for 2021, which is due in late February. And it'll be available to the public as early as next fall. There will be a 30-day preview period. It will be published on the Care Compare site, and there's also something called a provider data catalog, which is probably only wonky people like me go and look at with all the data files. They will not be doing validation for critical access hospitals on this data because they're rolling it together with the process for the inpatient quality reporting program, and critical access hospitals aren't held to that. So right now, none of the MBEquip's measures currently align with ECQMs, but F4HP is talking about how they might be able to use ECQMs as part of MBEquip. So I do definitely think that is the direction things are going. So I will pause for questions on ECQMs, and then I have a couple other things to share with you.
And please feel free to unmute your line if you'd like to ask a question, or chat a question in, and I will make sure that we get it addressed. And we'll just pause for just a little bit here to give you an opportunity.
This is Deb Hummel from Rush. I do have a very quick question about whether they're going to start building thresholds for ECQMs so we have comparison and benchmark data.
It's a great question, and I do not know.
Okay, thank you.
Yeah. I think likely because of the public reporting. I can't remember. I remember if I said this to this group because I do this presentation a fair amount. Prior to now, ECQMs have really been a black box. Can you get the data out of your IT system into the right format and into the, reported? The data never goes anywhere. It's just really been a black box. So I think with the shift to public reporting, people are going to be starting to really kind of look at that data in terms of quality. So I would be encouraging you guys to take a look at what measures you're reporting, make sure what the data is that's getting pulled out of your system is what you think it is, and be taking a look at how your performance is on those measures that are applicable for your hospital, because it is definitely no longer just going to be an IT exercise in terms of what they're looking at in terms of quality improvement and quality measurement.
Thank you.
We do have a comment in chat. Lori shared that we definitely review and discuss ECQMs, but have not yet done active quality improvement efforts. So if anyone has anything they would like to share with Lori on chat, or by unmuting your line, why, you're welcome to do that as well. Thanks, Lori, for sharing your comment.
Yeah, and I would just encourage you, as you're starting to think about your improvement plans for the coming year, where you're at, it might be worth thinking about your performance on those ECQMs. You won't have the comparison data available yet, but are you satisfied with what those measures look like for the ones that are relevant for you, because they are going to be plopped into that public reporting realm?
We already review them on a monthly basis here at Rush with our Director of Med Surg, who's also on the call.
Oh,
But
great.
we've already included them and put our goal is high, because when our data is publicly reported, we want it to look good.
Yeah. Thank you. Okay. Now, the
Okay.
stuff I'm going to talk about next is sort of on the horizon. Whoop, did I miss something?
No, I don't think so.
Oh, okay. Okay, so a couple things that are coming that I think are pretty important in terms of the bigger picture. So CMS is moving to something called a hybrid hospital-wide all-cause readmissions measure, where you would submit clinical variables and linking data elements that are combined with the claims data to calculate a risk standardized readmissions rate. So what happens now with your readmissions and your mortality data is they just use straight up Medicare fee-for-service claims. So I will also add a little bit of a plea to make sure that you're thinking about that accuracy and how good your coding is, because that plays into what currently is happening. If you have a claim for a pneumonia patient who also has CHF and diabetes, and the CHF and the diabetes are not coded, it doesn't get taken into account when they're risk adjusting for it. So just a comment that fits into lots of other reasons to be kind of doing complete and accurate coding, but it also plays in your quality data. So what they're trying to move towards, though, is taking the clinical data from your EHR and the claims data to do better risk standardization. So they did a pilot of this back in 2018. And then under the inpatient quality reporting program, there's a couple years now of voluntary reporting that have just started up now. The first year will be 21-22. And then they're going to start to require it for PPS hospitals starting in 2023 and 2024. So once they start requiring it under the IQR program, they are no longer going to calculate the claims-based only measure. So if you're not reporting the clinical variables, you will no longer have this calculated. And some of you might say, well, that's fine. But I have some concern about that, because readmissions is one of the most commonly used measures for value-based care purchasing, value-based care contracts. So if you're not submitting the data and you're not getting this calculated, I have some concerns that that will kind of be a gap for critical access hospitals. So it's submitted the same way that your ECQMs are, that QRDA file format. And then this is all of the clinical elements and the linking elements that would be submitted. So I have a link at the end to where you can find more information if this is something that your hospital is interested in kind of pursuing or thinking about. They just opened up the reporting period, won't be until next fall, I believe, for the last year. So there's some window here, but I do encourage people to be thinking about this. I also want to highlight for you what was in the this year's inpatient final rule, which just came out in August. If you deliver babies, there is something called a maternal mortality structural measure that is looking for participation in perinatal quality improvement programs. The initial reporting for that will be Q4 2021. This is, I think, an early attempt to try to get at a focus at some of the pretty horrible disparities in our maternal mortality rates in the country, but this is really just a first look. I anticipate there will be more measures related to maternal care coming out in the future, but this is kind of their first stab at that. They are also looking at a hospital hybrid wide all-cause standardized mortality measures. So similar to what I said about the readmissions measure, they are also going to shift to doing a calculation for that for the mortality measures. Again, it's got a couple years of voluntary before it becomes required. There is a COVID-19 vaccination coverage among healthcare professionals reported via CDC NHSN. That initial reporting period will be 2021, will be the last quarter of this year. I know Becky had sent me a question prior to the session. That measure is right now coming through under the inpatient quality reporting program, so is not required for critical access hospitals under that program because reporting is voluntary. It's also coming through the outpatient program, again, also voluntary. I would strongly encourage you to be prepared to report it. CMS is looking at trying to have everybody report vaccination measures. So at this point, at least for those two programs, it wouldn't be mandatory for critical access hospitals, but it wouldn't surprise me to see it come through some other way. And I don't have a good sense of, the administration announced a couple of weeks ago that they are going to require all healthcare workers in organizations that accept Medicare or Medicaid to be vaccinated. They haven't released the regulations or the rules of how they're going to implement that. So I have no idea how that's going to connect up. But I would just encourage you to be tracking. If you want to report or not is up to you, but at least be prepared to report in case something happens and you are required to end up reporting that. And it will go in the same way that you already submit. It's through NHSN, so you're already submitting your immunization, healthcare flu vaccination measure through that direction. There are 2 new ECQMs that will be available starting not until 2023, but they will be available starting in 2023, both related to hospital harm, a severe hypoglycemia and a severe hyperglycemia measure. So those were finalized in the 2022 rulemaking process, which the final rule just came out about a month ago. The outpatient perspective proposed rule is out right now. The comment period has closed, but they have not released the final rule yet. They are proposing starting in 2023 to remove OP2 and OP3, which are MBEquip related measures, and replace them essentially with an ECQM that's clinically similar to those 2 measures kind of combined up together. If this is adopted, it's significant because it would be the first ECQM under the outpatient program. Right now, all of the ECQMs are under the inpatient program. And then again, they're having the COVID-19 vaccination coverage measure is here too. It's essentially in every quality measurement program across every setting. CMS did put this in. There's also one called breast cancer screening recall rate. This will be calculated based off of claims, and they're looking at a performance score within a target recall range. So it doesn't, and I think there's recognition that no recall would be bad. That means that you're probably not calling back people that should be recalled, but that too much recall also kind of exposes people to too much radiation risk. So there's going to be a target recall range that they're looking at a performance score within that. So if this is adopted, the initial measure calculation period would be 2020 to 2021 and would probably come out sometime with a care compare refresh next year. I would guess maybe next fall. So you wouldn't have to do anything with this. It would be calculated for you if you do mammograms based off of your Medicare fee-for-service claims, but something to be taking a look at if that's a service you provide. Again, proposed, not yet final. And then they're also looking at for hospitals that are required to participate in OQR, again, critical access hospitals are voluntary. There has been optional reporting for a couple of years for these 2 measures, the OAS caps, the ambulatory surgery center caps, and the improvement in patient visual function following cataract surgery. So those have been available to report for the last couple of years, but optional. And now they're shifting those to mandatory under the outpatient quality reporting program. So that would be 2024 for the first one and 2023 for the cataract surgery one. And then there was a request for information regarding rural emergency hospital. If you've been listening to anything policy related in the rural health space in the last year or so, last 7 or 8 months, you've been hearing about the potential for a new provider designation type called rural emergency hospital, which would essentially kind of eliminate inpatient beds. They will be rolling out the regulations, the initial regulations for that in the coming year. So there was a request for information asking about for input on all sorts of things, including a whole section around required potential quality measurements for that new provider designation. So where does MBEquip fit with this? I anticipate you're going to continue to see a focus on measures that align with other federal programs. But again, my kind of reminder that we really need to continue to advocate for increased availability of measures that are relevant in the rural settings. I am optimistic. I don't think it'll be a short-term fix, but hopefully a longer-term fix. We've been having some great conversations with the CDC about trying to make some of the HAI data more meaningful. So I know a lot of you are reporting that HAI data, but the way that they calculate the standardized infection ratio just doesn't work well when you're a low volume facility. So talking with them about maybe alternative ways to use that data to calculate a quality measure. So I think that would be a good direction. I think that you are likely to see some potential focus around ECQMs, perhaps readmissions or those claims-based measures. And then there is exploration regarding measures related to other areas of interest, and that the Flex programs are all currently launching focused QI projects, which may or may not match up with the MBEquip core measures. And Becky, remind me what you guys are doing for your project in Indiana.
We're doing a small group of swing beds.
That's what I thought. Okay. So anticipated continued changes and updates to the measures. I know everybody would love to have a static measure set. It's not the environment that we live in. A couple slides and then I'm just going to stop talking. Okay. I always encourage people to provide input. Hearing from you guys about what works and what doesn't work in terms of quality measures for your hospital, super important. There's talking heads like me that provide that feedback, but it's much more valuable coming from you. So different ways that you can connect in on that. And then I just want to point out to you that there's several links to resources here. So the overall hospital star rating information, where you can find details on all the ECQM reporting. We have a great podcast, short podcasts that are available that we've put together with experienced quality improvement mentors from across the country. So if you haven't taken a look at that, I'd encourage you to do that. And then if you're looking for ways to help train staff on quality improvement basics, we have a free set of modules available, lots of templates and tools. So I will stop with that. What questions do you guys have? No, we're right towards the end of time here.
Yeah, we have about 5 minutes left. Karla, if you do go back to the one slide with the quality basics link, I do send these links out periodically with our monthly updates. And if you don't have your slides readily available,
I don't have them.
That's okay, because I do send them out, but they really are some nice presentations, particularly if you're newer to quality, and we do have some recent changes. Yes, these courses are very nice, and there are lots of nice tools that individuals have used that are out there. And if you ever have any questions about any of the modules or any of the tools or need assistance, just let us know and we'll be glad to help you out with that. So,
and those are all hyperlinked in the slides that Becky sent you. So
correct.
you'll be able to get to them easily.
And there are a couple of people that did find the slides that we forwarded in their spam. So if you didn't receive them, check there. But again, I think Karla has shared a lot of important information today, that if you do not have a copy of the slides, just send me an email that's to Becky Royer at ihaconnect.org, and I will get those to you. So
I know it was a lot. I hope there was some nuggets that were helpful. Love to hear how you guys are thinking about ECQMs, if you've been looking at your hospital star ratings. Anybody trying to tackle that, or is it just not floating to the top right now, which is completely understandable.
And feel free to unmute your line and share too. I do know that we have had some hospitals really focused on improving their star ratings and have been successful in doing so. We had a hospital recently obtain 5-star rating. So yeah, I know. So okay, well, I know that you're all very busy. So glad that you were able to join today. I hope that this was helpful. If there was a part that was a little confusing to you, let us know. We'll be glad to send out more clarification. And stay safe and take care of your families. And most importantly, take time to take care of yourself. So thank you so much, Karla, for your presentation today. And we'll be talking with everyone soon.
Yeah, thanks for letting me join you and for taking the time out of your day.